picture of circulation. It's giving us a picture. It measures, again, it's typically a 1 to 3 second period. Typically it calls for a break, and the muscle is tested in a relatively isometric manner at either its most shortened position or the middle of its range of motion. And again, isometric, no movement has to take place. Little movement, so we knew whether it was facilitated or inhibited, but it's not like you have to go wham. You have to go break if you're using a dynamometer and you want to objectively measure it. But at Tufts University, where I was visiting them, because at Tufts University, if you look in those references, the ones that say Mehta, Nosher Mehta has done an incredible number of studies using manual muscle testing to treat jaw problems. And when they do these studies, and they do them in a research environment at the university, they calibrate the students. So students that are going to do the testing are calibrated, and they're calibrated not to this, they do it to that, but they're calibrated to measure isometrically, which is the difference. Isokinetic involves movement. That's different. Failure of a muscle to meet demands of manual muscle testing can't be simply attributed to fatigue and neuropathy, and have been are shown to be associated with neural control. The appearance of muscle weakness represents motoneuron inhibition. Motoneuron inhibition is most commonly a functional rather than a pathological reaction of the nervous system. Functional neurologic changes reflect plasticity of the neuraxis, peripheral neuronal pools, and nociceptive input. So, here's the story. The central integrative system is defined as the summation of all excitatory inputs and inhibitory inputs. So we have, is it working or is it not working? If it's inhibited, then you have more negative inputs, inhibitory inputs. And what we're looking for is, again, facilitation. Okay, so we're looking to see changes brought about in the central integrative state of anterior horn motor neurons in the brain. It's a system of functional neurologic assessment. It's used to guide clinicians to therapeutic measures that restore optimum neurologic, respiratory, and postural functioning. That's the point. And it can't not be circulatory as well. The functional isometric strength of a skeletal muscle is affected by the central integrative state, which reflects changes elsewhere, such as in the nervous system, such as nociceptive input. Okay. Isometric deltoid press demonstrated optimal isometric facilitation in a maxillomandibular position, elevated more vertically and more protrusively than rest position. This increase in neurological function with anatomic realignment of the maxilla and the mandible could have huge implications relative to total body health and functional performance. So what's the significance of isometric? Isometric, we talked about a make or break. Isometric testing is, movement is not a factor. Isokinetic, movement is involved. So when that weightlifter takes that thing and goes up, that's isokinetic. And sitting there and doing the arm isometric. In isometric muscle activity, once more, no muscle movement occurs. The muscle contracts but does not shorten. By placing a limb in a specific position, single muscle isolation testing is possible. In with physical disability determination, they can identify which muscle specifically is not functioning and then is disabled. It measures gains in muscle facilitation occur only along specific axes on which the muscle contracts. Isokinetic movements involve muscles contract and shorten. Single muscle isolation is not possible, and isokinetic exercise involves coordinated movement of muscle groups. To do the isometric, we can isolate one muscle, and it's a healthy indicator muscle. It doesn't make any difference which one you pick. It's an indicator muscle. indicates facilitation. Okay, now you can impact neurologic function with biochemical status. You can input with changes in neuronal membrane potential, neurotransmitter levels, hypothalamic monitoring of blood, cognitive, emotional, and depressive. So the point is, you know, the patient might not test as strong with depressive disorders and emotional disorders, but this is the patient you got to work with. You got to do the best you can at the time you're doing it. So it measures the status of the central integrative system. We measure baseline, and we measure as an effect of the test or the challenge. And so in maximum mandibular registration with a vertical jaw position beyond freeway and a protrusive beyond edge to edge at maximum isometric facilitation, using the deltoid press, it's not logical to expect the elevator muscles to exhibit maximum EMG activity. This is important because if you are doing, let's say, bioresearch or myotronic instrumentation, for example, and you're looking to find a bite, and you want that patient to be able to eat better, you're looking for position of maximum strength. And so they use the electromyography to find that position where they get maximum strength. And that's the position that you can build an occlusion to. And that's a good position to build an occlusion to. But we're doing something else here. What we're looking to do is to balance the head on the spinal column. We're looking to get an increase of airway, and we're looking to get neurologic facilitation. So it's a different thing. It's two different things. It's not the same as using an electromyograph, and it's not, because if you have the position that your jaws are open 6 millimeters, as we found, and that was a position of isometric, that's not the maximum position of strength in your muscles, because your muscles are stretched. You can't take a stretched muscle and get optimum physiologic strength. You're measuring something else. You're not measuring magnitude of muscle power when we're doing that test. Got it? Okay, everybody got it? In the jaw position, if the elevator muscles are longer than rest position, muscle physiology shows that the muscles attain maximum EMG at their shortest position. Muscles know how to contract. And at their shortest position, then they get maximum EMG activity. Centric occlusion is a position of a maximum EMG, ideal centric occlusion, maximum EMG activity, and that's where the muscles demonstrated most power. And that power should be good, because that's where you want to be chewing. So neuromuscular dentistry using TENS, computerized jaw tracking, and electromyography is about finding a position of maximal EMG activity. We're not interested in that here. We're looking at maximum neurologic performance. A neuromuscular bite is based on a different science than the science I show you in terms of finding an oral appliance successful at treating obstructive sleep apnea and achieving oral airway dilation. And then I talked about the Tufts made a study group relative to jaw function. They've done 6 studies. When you go to the other literature relative to performance, it takes it to they've got 8 more papers. They've done an incredible amount of study on this at Tufts University. Manual muscle testing could predict which maxillomandibular position is most favored by the central integrative state. Is it reliable? Yes, it's reliable. Reliability is a necessary but insufficient condition for establishing usefulness. Good reliability doesn't ensure usefulness. Facilitation is useful. Okay, let's not go. There's the isometric deltoid press. And then according to the International College of Applied Kinesiology, you should test more than one muscle, and quadriceps femoris is always one of them. That's the technique for testing quadriceps. The dental chair lends itself to testing quadriceps. I find that if you just test whatever you can, deltoid standing up, it suffices. Pectoralis can be tested. And is it reproducible? Yes, it's reproducible. This is what the Cybex dynamometer looks like. This is not a Cybex, this is a microfet dynamometer. We have one here if you'd like to see it, demonstrate it during a break. You're welcome to play with it and see how it works and what the reproducibility is. It's very interesting because, Jan, when you felt like weak, for lack of a better word, when you felt inhibited, when you measure it, it's like, I find that in the studies that Gloria and I did, it's the difference between maybe 30 and 26 pounds of pressure. It's not like 30 pounds of pressure and 15 pounds or 10 pounds. It's not as it subjectively feels. That's interesting. See, if you want to do this, you may. That's the interest. That's another brand of dynamometer. They come with different tips. 11 separate studies have validated that manual muscle testing provides objective neurophysiologic measurements of functional status. These 11 studies are in your thing, and they're here merely for me to show that there are 11 such studies from refereed literature. And there's number 11. And the concurrent validity of a test refers, we're not going to deal with that either. Let's conclude this. Establishing the optimal maxillomandibular relationship for nocturnal airway patency for treatment of sleep apnea and snoring may involve positioning the anatomic parts similar to that for the least stressful position for proper functioning of the central nervous system. That's what we're looking for. More research to establish better understanding of the interrelationship of TMJ, airway function, posture, and the function of the entire nervous system is warranted. We need to know more. Okay, principles on which an ideal bite registration for an intraoral appliance is based. We said this before: maximum vertical height, lips together unstrained, maximum comfortable protrusive, and you should be nose breathing. You'll find your patients will still breathe through their mouth, and you'll find that it still works. I just find that I don't get those sensational results that I expect. Principle of clinical practice: there's never an always or a never. There's nothing that always works. Let's talk about muscle function. Muscles have an abundance of contractile possibilities. Muscles do not always function in the same way in similar circumstances. The same muscle does not always function the same way in all people. And so we have the regular anterior bite. Hard anterior bite shim limits the contraction of the temporalis. The masseter is not eliminated, therefore masseter dominant. The maxillomandibular registration 2, we call it also the distraction bite. The posterior hard polyvinyl siloxane limits contraction of the masseter, therefore temporalis dominant. So if we do this way, the bite that we took on Jan, if you used, let's say, 2 different color materials, it would look like this, where you could use a chocolate mousse for demonstration purposes, and the chocolate mousse was the posterior bite. That's the bite we said was stronger, and then we filled it in here, facilitating. It was facilitated, and we filled it in there. And then the other bite is the one where we took it here, we got a lock, and we fill in the posterior segment. So the distraction bite, the direction in the anterior bite is like this, and then the distraction bite, it's like that. The joint is unloaded a little bit more. Is there a difference? Yes, there's a difference. So mounted the case, if you take one bite, if we had the articulator and we have the 2 bites on you, and we mounted the case, this is the case. The anterior bite registration looks like this. Again, what we're seeing is there's a limit here. It can't close anymore here, but it can close a little farther in the back. And so this is what the mounted case looks like. Is this bite different relative to all the anatomy? Yes. Which one is the better? The one that's facilitated. Okay. And so with the distraction bite that we took, excuse me, with the distraction bite that we took, you get more like parallel. Is this going to function the same as this? I don't think so. I think physiologically we have a huge difference here. And we have to recognize these differences, and it's nice. Never say always, never say never. It's nice to have more than one technique because you may need it. 90% of the time, 95%, this is fine. And you'll get the lock. But then sometimes you need to do this. Again, there's no universal bite for making an oral airway dilator. TMJ and masticatory function is a complex subject that remains contentious. Knowing different bite registration techniques that redirect muscle forces and protrusion could increase both success and patient comfort with oral airway dilators. Okay, so now let's take this to another level because I think this is really important. So this is the way a lot of people take the bite. And when they take the bite with one of these, the answer is that this is going to take the jaw out. So you ask the question, well, how far protrusive should we go? And the answer is, you can't use any of these, in my opinion. Okay, so why is that my opinion? My opinion because, here's the story. What we did is, there's a study in the literature, and the study is repeated 3 times. That's all in your card. I don't remember who. One of them, which was Seymour Yale. Anybody went to Illinois? Nobody here went to University of Illinois. Okay. Well, Seymour Yale was the dean there when I went there. And so the studies varied between, I don't know, 129 maybe and 136 degrees of this angle. The problem was that they're only measuring this angle, okay? And so what happened was that I started looking at the pictures from the ICAT, and what I saw was that they always looked asymmetric, the condyles. So now what I did was I took a skull. Now, if you take off, if you ever have an ICAT, you can do this. You sort of like erase for a moment the panoramic radiograph. Now when you do that, you can rotate the skull. So what we do is we rotated the skull so the line between 8 and 9 intersected foramen magnum. And that I define as the sagittal plane. Okay? You're with me. Then what we did was, having defined the sagittal plane, we drew a line perpendicular to the sagittal plane, and the computer from the ICAT already measures the angle relative to that perpendicular. Okay? So it measured, for example, that this condyle was 23.9 degrees relative to the perpendicular to the sagittal. And then this one side here was 25.7. So what we measured was what we did was we found that the average condylar asymmetry, now one group, the control group, are the sleep patients and TMJ patients. The other group are the asymptomatic general dental patients who walk in the office. And what we found that there's an average of about 5.5 degrees asymmetry. Okay, so the point is that if you have the condyles as you see them, let's go back to here, it's a reasonable expectation that the jaw will come forward if you protrude. But if you've got condyles that are angled, it's a reasonable expectation that it's going to go one way or the other, asymmetric, because they got to go over the eminence, and they're angled, and they're asymmetric to each other. So what we found on the basis of this study is that there's about less than 5% of all patients actually have no asymmetry, and those are the ones, the 5%, you can use a George or a tap gauge or a metric, airway metric, because they're going to come straight out when they protrude. Everybody else, 95% of them, are going to go one way or the other. So, what is 5.5 degrees? How much does that mean? What does that mean to you? It means that if you take from foramen magnum, or if you take from the plane between the two condyles, what it means is it could be as much as the distance, that 5.5 degrees. If you look at your watch, 5 degrees is 1 minute. That doesn't look like a lot on your watch. But 5 degrees from the middle of your head to the edge of your central incisors could be as much as 6 or 7 millimeters. It could be almost the width of a central incisor. So you're going to go like this or like this, what I'm telling you, and not like this. So how can you direct and how can you find that movement? Ask the brain, use the manual muscle testing, and use the shims where it's perfect excursion with no interference to the side you want to go to. So I don't care if you don't like manual muscle testing, you have a hard time logically arguing that the shims aren't better than the other devices out there to pull the jaw straight out. See, the point is, when you're doing those shims to find the bite, as we did on Jan, the two nipples, the protrusions are up, and this is smooth. So it's like skating on ice. You can go any which way you want. There's no limitation in lateral movement. You want to come straight out, you can come straight out. And really what we should have done, but I wasn't that far ahead, is we could look at the midline to see where you straight. Now it's interesting, if you look at most people, you look at the person next to you at some point, most people are asymmetric. In centric occlusion, most of your patients are going to be off 3-4 degrees. They're 3-4 millimeters, 2-3 millimeters, something. Very few people are upper over lower. Even after orthodontics, if you're looking at your patients, they're not going to be upper over lower. And so the point is, how are you going to determine midline? Are you going to determine midline based on centric occlusion? Well, we know teeth aren't perfect and occlusions aren't perfect. We also know how much inhibition there is biting in centric occlusion. Why? Because it's imperfect. It's an imperfect position. It's a high stress position. So what we want to do is find the least stressful, facilitated position to record that bite, to record that maxillomandibular relationship. And you can do that with the shims, okay? And the point is with the shims, you can go in any direction to any degree that the nervous system and the eminence tells you. The least position you want, 5% of the time, you want them coming straight out, because that's correct. The protrusive movement is dictated by the eminence, the condyles, the muscles, the ligaments, and the nerves. That's what's going to dictate that protrusive position. If you let a machine do it for you that's pulling it straight out, it's going to be off 95% of the time. People have huge adaptability. So everybody that gets it pulled straight out isn't going to complain of pain. But I think if you do it this way, you'll see a lot fewer and a lot less pain. And so this is the story. We've got the paper. The paper is in your bundle. It's there to read. It just came out in July while we were at the Boston meeting, sleep meeting, and I think it's an important paper. Okay, what are we taking now? Practice. Now we're going to practice the bite. Excellent.
Does everyone have all the equipment they need? So go ahead and you can stand up and practice the muscle testing on each other. Dr. Moses will be walking around and he'll be happy to help you. I can help. Take your jackets off. We're all going to get mushy with the vanilla. Mushy with the bites.
Shoulder okay? Because you want that tactile.
How many did you use? So why don't you try 2?
Okay. Because then you can roll some lips. Okay, test.
Okay. Very strong.
Do 3. Don't lock it. Did you lock them? Put 3 together.
Yeah.
Okay. Let me show you. Just a second. Always handle them by these edges. Then you'll never get bit.
Okay.
Okay. All right, Sarah. Lips together, lips together.
Lips together.
Tongue in the roof of the mouth.
Tongue in the roof of the mouth. Strong.
That's a lock?
4 is weak, yes. 2 or 3, which
Lips together. Tongue to roof of mouth.
Okay.
He's getting a little broken down a little bit.
2 is better. 2 is better. Huh?
Cooling down a lot harder.
I don't know. He's can do it the same. Let's do 4.
If you folks need more shims or more tips or more vanilla bite registration material, please just shout. We have baby wipes. We have Anything you
Okay,
want?
yeah, that's not, no, take one away.
You're just two?
Okay, so let's do it again with 3.
All right, lips together.
Stand straight, stand straight. I feel like you're not.
Okay, and tongue to the roof of your mouth, Sam.
It's a feel thing.
He's strong.
All right, let me try it. Ready? That's a lot.
Block. Okay. Lock means what?
That's as good as it's going to get. Just don't get it. Okay. Now you got it. Okay, now let me show you. Just because. Hold it like this. Because you don't want, you want one shot and then put it in. That's it, so they're lined up. Hand me that.
Yes, sir.
Okay. Now, we're going to do extrude a thin ribbon. Don't lock them together in any way, shape, or form. Okay. I just don't do close. Okay, now hold it. That's just 1 minute. No, we only need set. So when that's set for a minute, then you'll be able to slide it. This is 3, right?
Yes.
And again, now look at the 3. There's no strain. So that's why I want to see. You can see his lips are comfortably engaged. With that little tackiness from the lip out. But see, sometimes if it's not tacky, it's a strain. So, okay. That's a minute. So now, no, stay there. You in the bite? Okay, now slide, don't bite. There you go. Okay, slide to the right of, 1 millimeter to the right of center. Arm up, tongue in the roof of the mouth, 1 millimeter to the right of center. See? Don't have to lock anymore. Now go to the left of center. Okay, we don't have it. Now, find your midline. Protrude as far as you comfortably can. There you go. You can chin yourself on that, right?
What's that?
You can chin yourself on that arm.
Yeah.
Okay, don't move now. Hold it. Now squirt it in. Squirt it in and just wait. Don't connect it. Only do the back That's it. Okay, don't go up too high. Just put it between his teeth. Good. Okay, now what we're going to do is we're going to make a little template. So that if you need to, you put it back and you close your lips. Now, you're going to open up just enough for him to slide that out, the anterior segment. Okay?
There, when it sets, right?
When it sets, he's going to open just enough, not to leave it in the back.
Just to pull the...
Just to pull it out. You're going to open up this much, half a cusp. So he can get that out of there. Good. Now you can put that back in if you need to. Just lay it down gently. What happens? I don't know.
It's still there.
Okay.
For the flash.
Okay. Now, test him again. Now you see? Now,
Okay.
now he's
Tongue
got
in the roof of your mouth. Right.
tongue in the roof of the mouth. And can you touch your lips as well? Okay. That's better.
That's better.
Better? Then now you just squirt it in. If it wasn't better, you'd have just sort of lock the two together.
Now, connect them, or...
Now you go all the way across and overlap. Where? I want to go see it, but I want to...
So if he's better the second way, just with the material in the back, the vanilla bite in the back,
Just leave the vanilla bite in the back and
and you
connect the
squirt it
front.
this way. If it's not quite as good, then you put the anterior back in and you connect everything up.
Yeah, or put the anterior back in, leave the posterior out, and squirt. You know,
Looking at him, wouldn't you think he's masseter though?
it's not. I don't like to think of it that way. Think of it as distraction bite and regular bite. Master, yeah, it doesn't hold.
Okay.
Lift
Can you feel the difference?
I could there, yes.
Can you feel the
When
patient?
I went right, it was weaker.
Yeah.
Exactly.
Now go forward. Go back to where it's most comfortable. Lips together. Okay, that's about it.
If you ask the brain will tell you where the bite needs to be. It's just remarkable.
It was weaker.
Yes. Yes.
So now you would take your gun and you would squirt
Squirt both
all the
sides.
posteriors, yep, and you'll connect the horseshoe. Okay? If you still don't get a lock, that's when Dr. Moses will say, okay, and he'll squirt a little bit in the posterior, and he'll take the anterior out, and he'll muscle test again. And then if that bite, where as a patient is more facilitated, then he'll connect. And he'll
Is that where I'm converted to a
That's
to
where you
a,
go to
a
the
masseter bite?
Yes.
Masseter dominance?
Correct.
Okay, sure, masseter. Prior to that, we're all.
He usually does a temporal spike. When he's muscle testing,
What am I doing here?
you're doing a temporal spike.
Temporal spine.
But when you're muscle testing, if you're not 100% or the patient is saying,
Exactly.
feel good, then you know what? Try that other bite.
Then put it in the back.
Put a little bit in the back
On either
and
side.
take that front out. Muscle test
When
the
you
patient.
put them in the back, when you put it in the back, do you have them squeeze?
No, you just squirt it in between, just the molar segment, and then just open it teeny tiny and take it out in the front. And then muscle test and biting on the back. It's totally different muscles. And you can try it. You guys should, I mean, just put a shim on your back teeth and then put a shim in your front teeth. You'll see how the whole muscle forces shift.
I've got to conceptualize it. Let's say we want to go to masseter dominance. I put a little bit back on either side.
Right, do it.
Then I
Go ahead, I'll watch
tease.
it.
Then I tease this out.
Yep.
Tease this out.
And now he's biting on his back,
The
on his
two,
right.
and then we're going to create a tripod up here.
And then what you want to do is muscle test him when he's got only that in the hand. Because if he's stronger there,
That's when
it's
you
more
put the anterior.
facilitated than say, you know what, we're doing that bite
Okay, gotcha.
instead of the anterior bite. Okay?
Very good.
And the first
Okay,
one,
let's
when you're
go to
biting
your,
in the front, that's your
perceived
temporalis.
experience.
Is that what it
Comfortable.
is? Or your masseter? I think your masseter.
That's a distraction bite.
So that's your masseter bite, when you have something in front.
Okay?
When that's out, then it's your temporalis bite, because your masseter.
I just know that he calls the bite where he just uses the back, he calls that the distraction bite. He's distracting the masseter, I believe.
10% of the time?
Yes. If he doesn't get a solid lock, then he will.
Then he goes to the back. Okay.
Yes, sir.
I had a question. I didn't get enough injected.
Don't worry about it.
Does he try and add to it?
No, never.
Never.
That is perfect. That's
adequate?
perfectly fine. Yeah.
Okay.
Well,
It's a little thin.
yeah, it is a little thin.
So,
Hold on.
so my question is it possible to add to it, or do you just do it over?
If you can get that back in the patient's mouth where it belongs without breaking it, then
Then
try
you
it.
can add
Yeah.
to it. That's
yeah,
what we were
yeah.
going to do, just for the heck,
Sure.
just to see if you could.
Give it a whirl.
Tell you when stuff and don't see if it doesn't work.
Just keep trying. Why not?
That's right. Let's do it again. Take three. Take four.
Yeah.
And
All right.
you know what?
We'll try it.
There's
and
no.
we got nothing to lose. I just need an
There's
extra
no
tip. If that's,
100% right way.
Yeah.
You take tips that you learned during this weekend and you incorporate them into your practice. You're your doctor. You're the doctor of your office.
right.
It's just, it's like, oh, where do I start sometimes? And that's why he is always a good. That's the hard part. So, okay, I want to see how you're going to do it. I'm going to watch.
All right.
Bite down. Then let's
Does
do the
anyone
other
have any
one.
more questions?
Bite down. It's just a little different where there's room for error. That's what it was. That we just learned. There's room for error doing it that way.
There's room for error anyway. There's no perfect way. Whatever way works in your hand.
This was more though because they don't self-level.
Yeah, they don't self-level. That's why. It was like, that is that. So people might, my appliance might not be in the right position.
Well, Guy Yatros is a brilliant guy. I mean, I'm sure he gets results. And, if he's using these, he gets a better result.
He loves these, he said.
Because again, you can't use the other stuff because if you're pulling them straight out, you're going to get in trouble. That's all.
Yeah.
But okay, go ahead.
Oh, we want us to do it again? We did it all.
You did it?